All right, I am showing it is 11 a.m. Central Time, which is our scheduled start. So we're going to go ahead and kick off today's program entitled ACA Update, What's Next, and Looking Ahead. Just a few housekeeping items before we get started today. Today's audio portion can be heard through your computer speakers or by phone. Please know that if you are listening by phone, all phone lines have been muted to eliminate any background noise. And if you are listening to the audio through your computer speakers, please understand that the audio connection is based on the speed and the quality of your internet. So if you do find periods of the audio getting choppy or in and out, I would encourage you to call in as opposed to listening to your computer speakers. A copy of today's presentation was emailed to all independent registrants earlier this morning, and we will send another copy along with a follow-up email thanking you for your presentation participation today. Lastly, this presentation has been pre-approved for one general HRCI credit, as well as one SHRM professional development credit. Certificates of completion will be emailed in approximately 3 to 5 business days from the conclusion of today's presentation. I should say I do have one other comment. If you do have questions, please go ahead and type those into either the chat function or the Q&A function. And at the end of the presentation, depending on how much time we have, I will address as many of those questions as I can today. For those of you who don't know me, my name is David Lindgren. I work for Flexible Benefits Service Corporation. My job title is Senior Manager of Compliance and Public Affairs. I spend a lot of time dealing with the Affordable Care Act, with the ERISA regulation, with Code Section 125 or the cafeteria plan rules, along with a lot of other employee benefit regulations. In the event you were unaware, today's presentation has been co-sponsored by two organizations, my organization, Flexible Benefits Service Corporation, as well as a payroll company known as Paycor. Just a couple pieces of background information about each organization before we get into the main criteria of our presentation today. Flexible Benefits Service Corporation also goes by the name Flex. We were founded in 1988 and are located in Rosemont, Illinois, just outside of Chicago. We have a number of different services that we offer, but in particular, we have two primary departments. The first department offers what we call consumer-driven accounts as well as compliance services. Through this department, we offer both health and dependent care flexible spending accounts. We have our own proprietary health savings account. We administer health reimbursement arrangements, as well as commuter plans that allow for tax-free parking and mass transit for employees getting to and from work. We do administer COBRA and provide a number of different plan document services such as the ERISA wrap document, as well as other cafeteria plan documents and more. With our reimbursement accounts, the FSAs, HSAs, and HRAs, we do have integrated debit cards so that employees don't have to always submit a manual claim for reimbursement. They can just use that card and access their funds available. We do have an online benefits portal, and along with that, we do have a mobile app to make access a little easier. And we publish online a number of different educational resources for both employers and employees. With our consumer-driven accounts and compliance services, we have approximately 3,200 employer clients amounting to more than 200,000 participants. Our other primary department we refer to as a general agency. Some people refer to us as a wholesale insurance agency, but we partner with insurance brokers and brokerages throughout the country to offer concierge-like services for them to help them support their group health clients, their individual health clients, as well as their Medicare clients. And through this department, we provide a lot of back-end support to help them with their sales, customer service, marketing, business processing functions, and more. Our co-sponsor today, I mentioned, is Paycor. They are an owner-led, employee-owned company since 1990, and they have more than 31,000 clients. They have a suite of services. I mentioned that they do offer payroll, but they also do have an HRIS system. They have onboarding tools, applicant tracking, and they also do offer ACA reporting services, which will be one of our topics today as well. Paycor has three things that they're primarily known for: their customer service, their technology, as well as helping their clients reduce their cost, engaging employees, and improving analytics and other compliance components. So we're glad to be a co-sponsor with Paycor on today's presentation. And I should add that this presentation is part of a series of webinars that we have been co-sponsoring with Paycor. This is the third webinar in a series of 4. Flex has taken the initiative to represent and provide informational material to you about the Affordable Care Act, and Paycor has taken the initiative to provide some information to you in regards to some new updated Department of Labor policies, including but not limited to the new overtime rules. So we hope that you'll find some of these webinars very helpful and informative. So that being said, that is my introduction to you about our organizations and some general housekeeping items. Again, as we go through our presentation, if you do have questions or comments, please go ahead and type those into the Q&A or chat function, and time permitting, we will address as many as we can at the end. So as we talk about the Affordable Care Act, this is a law now that was passed in March of 2010, but it still seems to be a topic that it really is almost an everyday talking item for employers, for HR professionals, for insurance agents, doctors, hospitals, really many people impacted by the Affordable Care Act. And it does go by a number of different names, whether it's the Affordable Care Act or its acronym ACA or Obamacare or healthcare reform. Whatever you prefer to call it is okay with us. Just understand that all of those terms and phrases are synonymous. But I think the reason that we're still talking about this so much is, number one, it was very impactful to many stakeholders, but we're talking about a law now that since its passage has more than 40,000 pages of guidance, and this comes from final regulations, from proposed regulations, from frequently asked question documents to other notices and disclosures. So the number of pages of guidance just is really increasing every single month, and continues to do so as the ACA evolves. And many in the industry would make an argument that this law is the most significant change to healthcare since the passage of Medicare back in the 1960s. So here we are 50 years later with a very, very impactful law. And 6.5 years since the law's been passed, we're finding a lot of confusion amongst business owners, HR professionals, and all sorts of people trying to really make sure they understand its impact to them and making sure they're doing the necessary things to comply with the law. And we expect that the law will continue to evolve, especially this year being an election year. We're really not certain what the direction of the law will be, depending on the outcome. If Hillary Clinton becomes the president, she has indicated that she would take steps to continue to implement the law, but would also make some changes where she saw some deficiencies in the law. Whereas if Donald Trump becomes president, he has indicated he would make efforts to repeal and replace the law, although he hasn't given a lot of specifics on how it would be replaced. And of course, any significant changes to the law would have to go through Congress, and we don't know what the makeup of Congress is going to be until after the election. So, we really have to pay close attention to this as we move forward into 27 as well as into future years. But when we talk about the Affordable Care Act, I really think there's a lot of things about it. While it is such a large and encompassing law, there's a lot of things about it that were or are easy to understand or comprehend from its impact to health plans. And just an example of some of those things that are generally a little bit on the easier side to understand is the requirement for health plans to now cover children up to age 26. In many states, prior to the passage of the Affordable Care Act, there was different rules on the age requirements, and the Affordable Care Act really makes a universal a benchmark or floor for covering children up to age 26. Also, something easy to understand is for your new hires who are eligible for coverage, generally cannot have a waiting period that exceeds 90 calendar days before their effective date of coverage. For those of you that are familiar with the term essential health benefits, these are 10 categories of benefits that include things like hospitalizations and prescription drugs, where health plans can no longer have an annual or a lifetime dollar limit on the amount of coverage for those essential health benefits. And then to the extent that you have a non-grandfathered plan, in-network preventive care must be covered at 100%, no copays or cost sharing to the employees or their covered spouses or dependents. But those are types of things that we really don't get a whole lot of questions about and seem to be relatively understood in a decent capacity up to this point. But some of the changes were or are more complicated. And these are some of the changes that we're going to talk about or revisit and hopefully provide you a refresher and tell you a little bit about where the direction of these rules are going. So the first of the three more complicated provisions is formally referred to as the employer shared responsibility provision. Most in the industry just refer to this as the employer mandate. And then there now is some new reporting that's required from some employers as well as some insurance companies and the insurance exchanges. And this is referred to as Section 6055 and Section 6056 reporting. You may not be familiar with those numbers, but these are the Form 1095B and Form 1095C documents that need to be provided to certain employees as well as their family members. And then what is not yet been implemented and is scheduled to now be implemented in 2020 is what the Affordable Care Act refers to as the excise tax on high-cost employer-sponsored health coverage. The nickname here that most in the industry are using, Cadillac Tax. So we're going to first take a look at the employer mandate and revisit that. The primary reason we want to revisit that is come 2017, the transition relief is officially expired. So the employer mandate will be said to be fully implemented for 2017 plan years. So I want to make sure you are up to speed with all of the requirements there. And it really is, I have this slide here entitled In a Nutshell, but it really is a rather complicated or takes a lot of time to define what the employer mandate is. If somebody were to ask me, I'd have to tell them that applicable large employers must offer coverage to full-time employees that has minimum value and is considered affordable or risk penalties. But each one of those boxes that you see on the screen really requires more definition. For example, who is an applicable large employer? And I think a lot of you are relatively familiar with that term now. The acronym is ALE or ALE. And the employer mandate applies to employers that have 50 or more employees. So for some of you, that's going to be very easy to determine if you have 50 or more employees. You have several hundred, if not several thousand employees. And for others, you may be closer to that threshold, and it may be a little more challenging to determine. But the way the regulations read is that to determine if you are an applicable large employer, we're going to need to base that on the average number of employees on business days during the prior year. So it's not the moment you hit 50, it's based on the average from the previous year. Well, not every business was in force in the previous year, so for newly formed businesses, the employer mandate applies if the employer reasonably expects and actually employs an average of 50 or more during the first year. So it almost seems like there's a little bit of subjectivity there because you really don't know exactly how many employees you're going to have, unless maybe you are a spin-off where there's a definitive number above 50. But it really seems like there's some subjectivity there and some assumptions that have to be made. So how the IRS will actually enforce that for newly formed businesses is still almost up in the air or yet to be determined. But for those of you that work for an employer that is a combination of multiple businesses, the controlled and affiliated group aggregation rules under IRS Code Section 414 do apply. So, for example, if you have a single business owner who owns a restaurant with 30 employees and that person also has 100% ownership in, let's say, a barbershop with another 30 employees, then 30 plus 30 being a controlled group makes 60 employees. Therefore, that controlled group, both entities are subject to the employer mandates. And employer size is not based on the total number of employees you have, or I'll say the total number of bodies that are employed, but it's based on full-time plus full-time equivalent. And what you may have traditionally defined as a full-time employee may be a little bit different as it relates to the employer mandate. And the employer mandate says a full-time employee is an employee who provides 30 hours of service per week or 130 hours of service per month. So it's not necessarily the actual hours that they're worked, but it's those hours that they work plus any additional paid time. For example, paid vacation, sick time, jury duty, paid leave, anything where you are paying the employee even though they may not be working is considered an hour of service. So if you have full-time salaried employees and maybe you give them 2 weeks of vacation per year that's paid, well, they're considered full-time employees during those weeks, even though they're not actually performing any work on your behalf. Then we have to take into look in determining whether or not the employer mandate applies at the monthly full-time equivalency. And we're really taking a look at how many part-time employees do you have, and do those part-time employees add up to a full-time equivalency that would put you into the 50 or more employee threshold, subjecting you to the employer mandate. So this really is primarily important for those employers that have fewer than 50 full-time employees, but maybe a number of part-time employees that could push their full-time equivalency above 50. So in determining your total full-time equivalency as it relates to the employer mandate, you would take the total hours of service provided by all of your part-time employees for the month, and you divide that number by 120, and that would give you your full-time equivalency. Now, for many of you, this part may have been a little bit of a challenge. If you do have a significant number of variable hour employees, those would be employees that at their time of hire, or maybe even if they are ongoing employees, you're not certain if they're going to work more or less than 30 hours per week or 130 hours per month. So to the extent you are considering holding off providing coverage to them because you're uncertain if they're going to be part-time or they're going to be full-time, the employer mandate says you can look at a previous time period worked and average those hours to determine if they're full-time, and if they are, you would assume full-time status for the following period. So there is a measurement period you can use. It's a 3 to 12-month time period to track the hours of service that a variable hour employee provides. And after that measurement period is ended, you have up to a 90-day administrative period to essentially, calculate all the averages for your variable hour employees to figure out who averaged more than 30 hours per week or 130 hours per month. And those that did should then be offered coverage in a subsequent time period that's referred to as the stability period. And this is the length of time coverage must be offered to those variable hour employees who average full-time status in order to avoid penalties under the employer mandate. And the stability period, please note, must be a minimum of 6 months, and it should never be shorter than the duration of the measurement period. So as an example, if you use a 9-month measurement period, those that measure full-time status should be offered coverage for a minimum of 9 months. The term minimum value is something that comes up and I do think is a little bit misunderstood, not necessarily at the employer level or the HR level or the insurance advisor level, but at the employee level. It is a new term. We're finding a lot of these terms employees aren't relatively familiar with, but when you take a look at the regs to try and simplify it or dumb it down a little, it says it's a 60% actuarial value. And the assumption, I think, from a lot of employees is that means your health plan is expected to cover at least 60% of your medical expenses. So after any deductibles or copays or coinsurance, it's expected to pay at least 60% of my expenses. But it's not quite that. It's not based on a per employee or a per covered person, but it's based on the total amount of benefits that are paid out for a standard population. So for those of you that have a self-insured plan, your plan would be expected to cover 60% of benefits of all claims received. So for some employees, their plan may, especially those that are a little bit healthier or that don't have a significant amount of claims, their plan may pay very little, if not anything, during the course of the year. But that percentage is going to be offset by those employees or those covered individuals that have a higher claims utilization. So really we're getting at a 60% average claims payout for the standard population, not any one particular person. And I think a lot of employees don't quite get that. They think their plan is going to cover 60% of their own expenses. And for some, sure it may, but for others, it may fall a little short of that. For those of you that have a fully insured plan, take a look at your summary of benefits and coverage, or your SBC. That's required now to determine if the plan has minimum value. And for self-insured plans, if you're not aware, the Centers for Medicare and Medicaid Services, or CMS, has a calculator. It's essentially an Excel spreadsheet where you enter in information about your health plan, deductibles, co-pays, and so forth, and it will give you a percentage at the end. And if that percentage is 60% or greater, then your plan would be considered to have minimum value. So there is a certain level of benefits that that plan has to have. Then as we move on to the employer mandate, one of the requirements is that not only the plan have minimum value, but it also be considered affordable. And this has been an administrative challenge, at least for some. We're finding some employers and some people that are trying to familiarize themselves with the affordability regulations are a little off in one area or another. But to understand affordability at its simplicity, it is a plan is considered affordable for the 2017 plan year if the employee's share of premium for self-only coverage, so we're just looking at how much it costs to cover just them, don't worry about spouses, children, or anybody else, for the lowest cost plan that's offered, so not necessarily the plan they're enrolled in, but the lowest cost plan that's offered that has minimum value, is not more than 9.69% of their household income. Some of you may have heard the number 9.5%. That was the original affordability percentage, but that is adjusted for inflation each year. And for the 2017 plan year, it's going to be 9.69%. This year, in 2016, it's 9.66%. But I have underlined their household income. I'm going to guess that most of you don't know the employees at your organization's household income. You probably don't want to even know it, or you don't have any reason to know it other than the Affordable Care Act telling you, or the employer mandates telling you you need to know it. And after the regulations were posted, the IRS realized most employers don't have access to that information and it would be a challenge. So they came up with 3 alternative affordability options that you can use. So the first option you can use is you can base coverage as being affordable based on box 1 of the current year W-2 wages. So this is an easy, you can calculate what's the annual premium that an employee would have to pay, what's their annual wages according to box 1, and if that's not more than 9.69%, it's affordable. So easy to calculate, but you can't calculate it until after the year is over. So if you have employees who have a reduction in hours or pay changes, you may come into this thinking coverage is affordable, but it may not actually be based on certain situations that change. So I think an easy method to apply, but the fallback or the drawback is I can't apply it until after the year is over. So option number 2 is what's referred to as the monthly rate of pay. And this is going to be based on the employee's pay at the start of the plan year. And for your employees that are paid hourly, you're going to take their monthly rate of pay at the start of the plan year and multiply that by 130 hours, regardless of their actual hours worked. We know many of your employees probably work 40 or more hours per week, so that would be roughly 160 hours per month. But the regulations say base affordability on 130 hours, even though they may actually work more than 130 hours. in determining affordability, as that is the threshold of a full-time employee as it relates to the employer mandate. For your salaried employees, you would just take their salary at the start of the plan year and then divide that by 12, and a 1/12 of their salary would be the number to use in determining whether or not coverage was affordable. One thing to point out for those of you that do have employees that receive tips of any kind, or you have employees that are paid exclusively by commissions, the rules say you can't use the monthly rate of pay, which would seem to make sense because you don't know what their actual pay would be during the course of any given month. The third method to use is, we refer to it as the federal poverty level method, or the FPL. This is where you're going to base affordability in relation to the most recently published federal poverty level for a household of one and the most recently published level at the start of the plan year. Just to give you an idea, that 9.69% of that number is roughly $95 per month. Again, that's just a rough estimate. There's a give or take $1 there. Just understand that that would be the number. If you apply that number, or that's the premium used for the lowest price minimum plan offered for self-only coverage, then you would be considered affordable in relation to the federal poverty level. Now, you now have an idea of, who an applicable large employer is, who full-time employees are, what minimum value is, and what affordable coverage is. Some of that stuff you've maybe rather familiar with, but the penalty adjustments may be something new to you. These are inflation adjusted. It originally was set at $2,000 for what I refer to as the A penalty. For those of you technical people, this would be part of the Internal Revenue Code, Section 4980HA. And this would be when an employer does not offer coverage to enough of their full-time employee population. Originally, as part of some transition relief, employers just had to offer coverage to 70% of their full-time employee population. That has been phased out for 2016 and into 2017. So the offer rate, if you are an applicable large employer, to ensure no penalty under this, is that you have to offer coverage to at least 95% of your full-time employees, as well as their dependent children up to age 26. There doesn't have to be any contribution for those children, but you do have to extend the offer to those children. And the penalty will be triggered if you fail to meet these offer rates and at least one full-time employee goes out to the insurance exchange, for example, healthcare.gov, applies for a plan and receives a subsidy or assistance in helping them pay their premium. And if that occurs, then the penalty, you take the total number of full-time employees you have. They do give you a break on 30 of those employees, but let's say you had 100 employees, you'd subtract 30, and you're going to take that number, 70, and multiply it by the dollar threshold you see above, and that would be your penalty for failing to meet the offer requirement. Now, one thing to point out, I've annualized the numbers here for simplicity, that the penalty is prorated on a monthly basis. So as an example, if you did meet the offer requirements for half of the year, but then fell below the offer threshold for the second half of the year, then you're really going to be looking at paying 6/12 of the penalties that you see on the screen. So those penalties for this year, inflation adjusted to $21.60, next year $22.60 estimated on an annual basis. So next is the B penalty, which can be found under Internal Revenue Code 4980HB. And this is when you meet the offer requirements of at least 95%, but for some of the full-time employees, coverage is either unaffordable or does not have minimum value or a combination of both. And so assuming you met those offer requirements and coverage doesn't have minimum value or is unaffordable, and the employee waives the group plan, goes on to the exchange and receives a subsidy, that's going to be the penalty trigger. But with this penalty, it only applies to the full-time employees that are actually receiving a subsidy. So it doesn't apply to the whole universe of full-time employees minus 30 like it does with the A penalty. And when I say B penalty and A penalty, those are just nicknames that we use. But This is, again, going to apply just to those that receive a subsidy. So, for example, in 2016, let's say you had 100 employees. For 5 of them, it was unaffordable, and 3 of the 5 went out to the exchange and got a subsidy. Then you would take 3 and multiply it by the number you see on the screen, 3240 for 2016, 3390 estimated for 2017. And that's going to be your penalty exposure under the B penalty. Similar to the A penalty, this is prorated on a monthly basis. So moving forward, this is something new to many of you, as it is the first time the ACA has implemented what we refer to as the notification program. And lots of confusion around this because many employers started to receive notices in the mail for the first time, instructing them that some of their employees have received a subsidy in the exchange. And it's notifying you that it would be a separate notice for each employee. When an employee goes onto an exchange and does receive a subsidy, they are asked information about their employer. It's not mandatory information that they provide their employer's name and contact information. It is optional. But to the extent they do apply, get a subsidy, and provide that exchange information or that employer information, the exchange is going to send out a letter to the employer. At least in most instances they will. And it's going to let you know that these employees received a subsidy. And employees can only receive a subsidy if they do not have access to an affordable health plan with minimum value, or they're not enrolled in the plan. So even if coverage is unaffordable or doesn't have minimum value, but they enroll, that's going to disqualify their subsidy eligibility. So they're letting you know that, hey, there's some employees of yours that are getting subsidies. Do you want to appeal that? And you have the option to appeal. You'll have 90 days from receiving the notice or the date of the notice to send an appeal that will you'll attest and possibly have to provide follow-up documents that indicate whether or not a particular employee is enrolled in your plan or was offered a plan that was affordable and had minimum value. And you might want to be proactive and appeal those to reduce or eliminate any potential penalty. But the appeal program is optional. This is not the end-all, be-all determination as to whether or not you're subject to a subsidy or to a penalty, I should say, under the employer mandate. The end-all, be-all is the ACA reporting under Code Section 6056 that we're going to get into here momentarily. So we're going to revisit the reporting, which again was the this year was the first time it was required, and it was required for the 2015 calendar year. For most of you, had to be submitted to the IRS by the end of June. So we're just a few months out from when that was done, but want to revisit that, its purpose, and talk a little bit more about where it's going. So the reporting itself has 3 different purposes. And the purposes are to help enforce the new shared responsibility provisions, which many of us call mandates. But it's the IRS needs this reporting to help enforce the individual mandate, which is the requirement for most people in our country to have a health insurance plan or pay a penalty. The reporting is used also to help enforce the employer mandate and make a determination as to who is or isn't eligible or who is or isn't subject to a penalty. And it also helps the IRS determine retroactively who actually was eligible for a subsidy in the exchange. Again, if an employer did offer coverage that was affordable and had minimum value, or an employee was enrolled in your plan, that's going to disqualify subsidy eligibility. So 3 purposes of the reporting that you see on your screen there. Now, we use these numbers, Section 6055. These are references to the section of the Internal Revenue Code that defines the requirements to do this reporting. But Section 6055 reporting has to be done by employers of any size, both small and large, offering a self-insured plan. Okay, that will be your employer responsibility. You have to look, is your medical plan self-insured? If so, you're going to be subject to this reporting under Code Section 6055. 6055 is what I refer to as the individual mandate reporting. This is the reporting required to determine who actually was enrolled in coverage and which months during the year they were enrolled in coverage, as the individual mandate penalty is also prorated on a monthly basis. Employers that are subject to Section 6055 reporting have to report coverage for every person covered under the plan. So you're identifying the employees, their spouse, their children, domestic partners. If you allow non-employees like independent contractors or former employees like retirees or COBRA beneficiaries, whoever it is, if they're covered under your health insurance plan, you have to report the months that they were enrolled in coverage under Code Section 6055. Again, this is the individual mandate reporting, which is why all of these individuals have to be reported. Fortunately, for those of you that do have a fully insured plan, the reporting process is done by the insurance company or the insurer, so you don't have to worry about 6055 reporting with that respect. The Section 6056 reporting, on the other hand, this is what all applicable large employers have to complete. So if you did average 50 or more in the prior year, or you're newly formed and you expect to have 50 or more this year, you are subject to the Section 6056 reporting, which is primarily going to be a report to the IRS of the full-time employees that you have and whether or not they were offered coverage that was affordable and has minimum value. Just understand, unless you have a special arrangement with an insurance company, the insurance company never completes the Section 6056 reporting. This is the responsibility of the employer who is sponsoring the health plan. So just keep that in mind. We found some folks that just assumed the 6056 reporting would be done by the insurer only to find out the hard way, and now they're in a situation where they're filing their reporting late. The forms that are need to be completed depend on a few different factors. Number one, your size, and then as well as the type of coverage that you're offering. So for those of you that are not applicable large employers, you have fewer than 50 employees. If you have no coverage, there is no reporting. If you have a fully insured plan, you don't have to worry about anything. The insurance company is going to take care of that. But if you have a self-insured plan, that's where you're going to need to complete Forms 1094B, that's one per employer, and Forms 1095B, that's generally one for each employee or each primary insured would probably be a better term to use. Then for those of you that have 50 or more employees and are applicable large employers, you're going to use what I call the C forms. So even if you don't offer coverage, you're going to be subject to reporting using these C forms if you are an applicable large employer, because the purpose is to determine, did you offer to enough full-time employees, and did that coverage have minimum value, and was it affordable? So you will need to complete one Form 1094C and then one Form 1095C for each full-time employee. Just understand there are 3 sections to this form. You only need to complete the first 2. Similarly, if you are an applicable large employer and you offer a fully insured plan, you're going to complete those C forms, but just parts 1 and 2. However, if you are an applicable large employer that does offer a self-insured plan, you're going to need to complete Forms 1094C as well as 1095C for each full-time employee, and you're going to have to do that all 3 sections. Again, the reason being you have to do all 3 sections is that you have an obligation to report information to determine if you're subject to the employer mandate, but since coverage is self-insured, you have to report information that helps facilitate the individual mandate. So they've streamlined it as opposed to having you complete 2 separate forms, the B's and the C's. You just need to complete the C forms, and there's a special section for you there. Now, the deadlines for the 2016 reporting, so you don't complete the 2016 reporting until after the year is over, is that these dates are a little bit earlier than they were for this year. But you need to, any person who you fill out a Form 1095B or a 1095C, depending on your situation, you're going to need to provide a copy of that to that particular person by January 31st. So this is going to be similar deadlines to W-2 reporting. So we're already, getting close to the end of October here, so you really need to start thinking about your plan for the ACA reporting if you don't have one in place already. But the reporting will be due to the IRS a little bit later. That if you're filing manually, you'll have until the end of February, and if you're filing electronically, you'll have until the end of March. Understand that if you're filing 250 or more of these forms, the IRS requires you to file electronically. So right now we're just kind of in a I'll say a little bit of a waiting period to determine whether or not the IRS is going to issue an extension. This year for the 2015 reporting, they did give some extra time with it being the first year, and it sounds like there was a lot of administrative challenges for employers. So we're crossing our fingers that maybe they do give another extension, allowing some additional time. But as it stands today, there is no extension, and these are the due dates for the 2016 reporting. In relation to the reporting, if you are going to do it on your own, that's okay. It may be administratively challenging in certain situations, but I do just want to make sure you're using the 2016 form version. Every year there's going to be an updated version. The 2016 form versions just came out, so make sure you have not started to complete these forms using the older templates. And then also, each year the instructions can be adjusted, and there were some slight modifications to the instructions this year. If you take a look at the instructions, which are available online in a PDF format, as well as an HTML format, at the very beginning, the first page or two will be a summary of the changes. I will tell you the most significant change that we've been able to catch, these instructions just came out a couple of weeks ago, was that they've changed some of the coding that you would need to use as to how to code people that are enrolled in your coverage, but they're enrolled by virtue of COBRA. So you'll want to take a look at that process being a little bit different than what it was this year. And my organization does not do the ACA reporting, so I'm not soliciting anything here. But just want to throw out there: have you considered outsourcing? There are a lot of organizations out there, payroll companies and others, that do have the ACA reporting service available to you. Of course, there's generally an administrative fee that comes with it. But these are folks that spend a lot of time and money sorting through how to code these things properly and how to gather information electronically and streamline the process. So if it's become a headache to you, it's something you might want to at least explore. So moving on, just want to point out one thing as it relates to the reporting and the need to try to do it to the best of your ability, or to have somebody that can do it on your behalf to the best of their ability, is that there are some costly penalties if the reporting's not done, or if it's done inaccurate, or if it's submitted late. And if you're subject to the reporting and you just choose not to do it, and maybe that's an intentional choice, maybe it's an unintentional choice, but the penalties can be as high as $500 per person. So they break down the penalty being, it's $250 for not filing a form with the IRS, and it's another $250 penalty for not providing a copy of the form to what we call the responsible individual, which would be your employee or your primary insured. They do cap the penalty for not doing the reporting at $3 million per year, but that's a pretty big number if you ask me. Now, there are other penalties that apply, and those penalties apply, for example, if the reporting is inaccurate or incomplete, you forgot to check off some boxes or add some information. This first year that reporting was due, the IRS said they're going to offer some good faith reporting relief, meaning, in other words, in simple terms, give it your best try, and as long as you give it your best try, we're not going to penalize you if you didn't fill out the form to the way that they expected you to fill it out. As it stands today, just like they haven't announced any deadline, they have not made any announcement that this good faith reporting relief will apply for the second round of reporting next year. So as it stands today, you have to go into this thinking you need to do this really to the best of your ability to limit, if not completely eliminate, any sort of errors or inaccuracies. So some costly penalties that could come into play for the reporting. Now, I just want to shift gears a little bit and talk, at least to the best of my ability, about the so-called Cadillac tax with you. And the reason I say to the best of my ability is we don't have any proposed regulation on this yet, other than the original content that was included in the final version of the Affordable Care Act. There have been a couple IRS notices that I'm going to mention here about this, but we don't yet have official proposed regulations, yet alone final regulation, as it relates to the Cadillac tax. We're still a few years out from implementation, so I can just speak to what I know and really what's publicly available so far about this. And just in a nutshell, what is the Cadillac tax? And it is a tax that's applied when certain employees enroll in coverage that is deemed too rich in benefits. And I'll walk through this if you're not extremely familiar with this, but the tax that's been identified is it'll be a 40% excise tax on values that exceed certain defined thresholds. And the thresholds that were used in the Affordable Care Act were $10,200 for single coverage and $27,500 for family coverage. Those numbers will be inflation adjusted. So when we get to the first year of its implementation, assuming it doesn't get further delayed or repealed, those numbers will be inflation adjusted at that point in time. There's also going to be higher thresholds used for certain demographical situations, such as health plans that cover high-risk professions or health plans that cover retirees. So those thresholds will be a little bit higher. And it sounds like they're taking into consideration adjustments for other reasons. For example, a health plan that maybe covered a larger percentage of older employees. Generally, those health plans cost more than those that would cover a significant percentage of younger employees. Or there could be a factor that's used for geographic location. For example, my company is located in the Chicago suburbs, and coverage in the Chicago suburbs can be 20 to 40% more for the exact same plan that would be in central or southern Illinois. So there could be some factors that are applied here to adjust those values upward for those individuals or those organizations that have health plans that are affected by certain things like geographic location or the makeup of their employee population. Now, the original implementation year was supposed to be 2018. That now has been pushed back to 2020, and its start date, again, is expected to be calendar year 2020, but that could change. So a lot of people have heard about the Cadillac tax, have a general understanding of what it is, but haven't really understood why or what the purpose of the Cadillac tax is. And we've really been able to put that into three buckets. The first is to limit the tax-preferred treatment of employer-sponsored health care. Most things that are out there, think of like a 401k plan. There is a limit as to how much a person can put into their 401k each year. Right now, there is not a limit as to how much health care can be provided tax-free. And health care can be more than just the health insurance plan. It can be health savings accounts, flexible spending accounts, health reimbursement arrangements, the ability to pay for other premiums like dental and vision with tax-free dollars. So it's more than just the insurance plan alone. And in fact, healthcare, in particular employer-sponsored healthcare, right now is the largest tax deduction out of anything else in the country. So more than retirement plan contributions, more than people being able to write off their mortgage interest on their individual tax returns, more than anything else. So we're starting to take a look at maybe we should put some limits here on that. Another secondary reason is to reduce excess spending on health care by employees or anybody covered under the group health plan. The idea behind some of these plans, or the thought process is, at least, if you have a very rich plan, a very low deductible, not too many out-of-pocket costs, maybe a very, very broad and open network, that if somebody has a minor illness or a minor procedure, they're just gonna run to the doctor, or they don't give much thought into considering having a procedure done in a hospital, which might cost 2 or 3 times more than in an outpatient facility, or they don't give too much thought into maybe considering a generic drug as opposed to a more expensive brand name drug. At least this is the thought process that some regulators had, that very rich plans might encourage overutilization and unnecessary health care. And part of the goal of the Affordable Care Act is to slow, if not reduce, some of the spending for health care. And then the last reason here is to finance the Affordable Care Act. The Affordable Care Act isn't free. There has to be a way to provide, for example, subsidies to people that buy coverage in the exchange, or in many states, Medicaid was expanded as a part of the Affordable Care Act. So they need to generate revenue that helps support some of these other Affordable Care Act initiatives. And some of those things are the individual mandate, the employer mandate, and also the Cadillac Tax. So moving along here, I did indicate that we don't really have a proposed regulation yet, but we do have 2 notices that were issued by the IRS. And I like to refer to these as the request for public comment notice, because really what the IRS has done here is they've issued notices and they've really said, this is what we're thinking about. Let us know your feedback as we start to formulate and propose actual regulation. So the first notice, both these notices came out in 2015. The first one, notice 2015-16, is what I kind of call the what plans are included in the value notice. So you saw those numbers, 10,200 and 27,500. Well, what plans are going to be used to determine if we hit those numbers? And then notice 2015-52 came out later in 2015, and this is what I like to refer to as how to calculate the values of coverage. So, okay, the first notice tells me what plans you're thinking about, including now how do I determine what the actual amount is? Did I go above or under those thresholds? Unfortunately, the comment periods are over, so I can't formally respond to those notices anymore, but I will break down to you what the initial comments or in those notices were. So there were, as I mentioned, the healthcare itself is generally more than just the health insurance plan when we're looking at the values, and sort of the tentative plans that the IRS listed to be included in the value will be your health insurance plan, will be employer and employee contributions to flexible spending accounts, as well as employer contributions to health savings accounts, and employee contributions, but only to the extent they're making those contributions via pre-tax salary reduction. Some employees might make contributions to their HSA on their own outside of the employer, and those would not be included. Health reimbursement arrangements would be included. If you have an on-site medical clinic, that's going to be included. They indicated that self-insured dental and vision plans might be included, but in the second notice, it sounds like now they're thinking maybe not there, so hopefully that's a good thing. If you do offer specified disease or illness plans, things like cancer only or critical illness, any sort of hospital indemnity or fixed indemnity plan that pays a fixed dollar amount upon an employee experience something like a hospitalization. These are plans that generally are used to help an employee cover some or all of their deductible. Those are going to be included if those plans are paid for on a pre-tax basis, as well as some other plans. Now, the second notice that I talked about talks about how to calculate the value of coverage. And the tricky thing from an administrative standpoint, you're going to have to calculate the value of coverage separately for every single employee enrolled in your plan, and you have to calculate that value month by month. And the reason being is the coverage that they have could vary from one month to the next. Somebody could start out with single coverage, during the middle of the year get married, and then have family coverage. There's qualifying events that may allow somebody to add or subtract coverage. So it is something that you're going to need to look at on a month-by-month basis. And in this particular notice, they did indicate that the value of coverage is going to be the COBRA applicable premium for each plan. So for some of those, that's pretty easy. Most of you probably have an idea of what the COBRA applicable premium is for a health insurance plan. But what about something like the COBRA applicable premium for an on-site medical clinic? You know, they haven't really given us direction yet on that, but that's what future rules are going to be. So some of these plans right now, there's not really a preset way to determine the COBRA applicable premium. So some people provided public comments on what they thought should be the COBRA applicable premium. And for the Cadillac tax, who pays it? For fully insured plans, it's the insurance company. For self-insured, self-administered plans, it's going to be the employer. For self-insured plans where there's a third-party administrator, the guidance is really unclear. Depending on how you interpret some information from these notices, it sounds like it could be the employer, or it sounds like it could be the third-party administrator. So we'll need some more guidance there. But just at a high level, from a process standpoint, plan sponsors or employers are going to need to submit reporting to the IRS. And if somebody other than the employer has to be paying the tax, then you're going to have to notify those parties of their responsibility. And again, the exact process is yet to be defined. So I just want to give you just a very simple example. And for simplicity, I'm just going to use annual numbers, even though I told you this does have to be calculated on a month-by-month basis. This is just for high-level illustrative purposes. Let's say, as an employer, you offer a fully insured medical plan to an employee, and that COBRA premium on an annual basis is $9,000. Let's say that employee enrolled in that plan, it's HSA compatible. They also put a $3,000 contribution to the HSA. So the combined value is $12,000. That's $1,800 more than that $10,200 threshold. So we're going to have to take a look at what's the insurer's responsibility and what's the employer's responsibility. Well, the health insurance plan makes up 75% of the total value. So the health insurance company is going to have to pay 75% of that excise tax, or so we're going to have to take $9,000 divided by $12,000, multiply that by the $1,800 that's over the limit, and then multiply it by the 40% excise tax. So the health insurance company would have to pay $540 in tax. The employer, that HSA contribution makes up 25% of the total value. So we're going to take that percentage, multiply that by the $1,800 that's over the limit, multiply that by the 40% tax, and the employer would have to pay $180. So the future of the Cadillac tax, there is opposition to the Cadillac tax from both political parties. On the Democratic side, they have a lot of support from unions and labor organizations who are largely opposed to this because their thresholds will likely be over that amount come implementation year. On the Republican side, just have a lot of those political officials that are opposed to just about every provision in the Affordable Care Act. If the reporting gets implemented as is, it seems like it's going to be a very complex process with a lot of administrative work unless there's some change as to how they decide to implement this. There is a good chance of some change to this, possibly even a repeal. You know, you can only speculate what's going to happen, but the question that nobody really seems to have a good answer for yet is, how does the government make up for the revenue that the Cadillac tax was supposed to provide to help finance other provisions of the Affordable Care Act? And that's kind of where we sit today with the Cadillac tax. So just a few final comments here. We're getting close. I got a couple more minutes here to wrap things up. Just from an employer mandate perspective, I mean, the key thing is to know if you are an applicable large employer and if you have any penalty exposure. From an ACA reporting standpoint, there's a lot of administrative work that will be required. It was required this year. It's expected to be similar next year. So just have a plan in place, whether it's something you're going to do internally or you want to explore externally. Just understand if you're going to outsource it, you probably really need to look into finding a vendor to help you sooner than later, since we're getting close to the end of the year. And the Cadillac tax, because we don't have really true proposed guidance yet, the best advice I can give is you just got to start thinking about it. Do you think you might be subject to the Cadillac tax? If so, how much? Are there changes you might need to consider? But I think the biggest thing is we have to wait for future guidance to really know what's going to happen. So with that being said, just want to thank you for your time today. Just a couple reminders. The HRCI insurance credits will be available within 3 to 5 business days. Along with that, we are going to send you a copy of the PowerPoint presentation. You should have had a copy in advance, but we'll send another. We'll send both of the certificates of completion along with some additional resources. I do want to add that our 4th and final webinar in our co-sponsorship with Paycor is expected to be on November 16th, and it's going to be an update on some Department of Labor policies, including but not limited to some more information on the Department of Labor overtime rules. With that being said, I'm going to open it up for a handful of questions. I see we are right at 12 noon Central, so I'll just take a couple, and then we'll try to follow up with you at a later date. So let me just read through here. Several questions have come in. There is a question just in regards to affordability, confirming if we use the prior year's W-2 or the current year's. And you do need to use the current year's, which is why you can't truly know if coverage was affordable until after the year was over. There's a question regarding the notification program. Is there any reason to reply to these if there were part-time employees? It's really up to you. If they're not going to have any impact to the employer mandate and they're not going to be reported on, probably don't have to. But you would only be replying to them if you're going to dispute their eligibility for coverage. So if you believe they are eligible for coverage, there really wouldn't be any reason to dispute that. Again, there is a question, how is the Cadillac tax value calculated? By annualizing the premium. Again, went through that. We're looking at the COBRA applicable premium. We got to calculate the values on a monthly basis. We've got to include much more than just the health insurance plan. We're talking FSAs, HRAs, HSAs, and some of these values have yet to be defined how to calculate. So hopefully that helps clarify that. Okay, a couple questions. Will the webinar be available afterward? We do record these, so I can ask to have a recording sent as well, but the slide deck will also go out. Okay. So for a couple of you said there were some audio issues. I do apologize if you were listening on your speakers. Sometimes the internet connection is not that great, and I do apologize if there was any audio connection issues via phone. So I'll take one more question here, and then I'll try to have some of our team follow up just for the sake of time. There's a question about the essential health benefit. What exactly does no dollar limit mean? It means plans in the past used to set maximums either on an annual basis or a lifetime basis. So, for example, they may say, we'll cover prescription drugs, but the plan will not pay out more than $50,000 a year for prescription drugs. So if you incur more than $50,000 in prescription drugs in any given year, you as the insured are now responsible for anything above $50,000. When the essential health benefit regulations came out, they said you cannot place any dollar limits on those on anything that's classified as an essential health benefit. So using prescription drugs as an example, the insurance company, or if it's a self-insured plan covering prescription drugs, could not limit the amount that the plan would pay out in prescription drug benefits for any given year or over any given lifetime, the entire life of the policy. So I do show we are a couple minutes past 12, and for the sake of time, I'm just going to wrap things up. I do appreciate everybody's time today. If you do have questions, you're more than welcome to visit our website or call one of the phone numbers that you see on the screen. I will try to print out these questions and have the appropriate parties send you an email response if I don't think we got to your question. But thank you very much for your time, and be on the lookout for some follow-up materials from us, as well as an invite for the next co-sponsored webinar with Paycor. It'll be hosted by Paycor on some of those Department of Labor policy updates and helping you put together an action plan to respond to those changes in policies. Thanks very much, and have a great day.